Today's panelists include Dr. Sonia Qasba, Suburban Hospital's epidemiologist, medical director of the antimicrobial stewardship, pediatric ED physician and hospitalist, Dr. Stephen Correa from Pulmonologist PC of Montgomery County, and Dr. Andrea Lerner, medical officer in the Office of the Director at the National Institute of Allergy and Infectious Diseases at NIH. And without further ado, I would like to introduce Dr. Sonia Qasba. Thank you.
Eleni, thank you so much for that wonderful introduction, and I want to thank the community for joining us today. As some of you may know, I actually grew up in Bethesda. My folks still live right across from the NIH, so I feel like you know, you're our community and my community personally too. And today I have two fantastic speakers with great knowledge in the talks that they're giving, and I'm going to actually introduce them in the order that they're going to speak. So Dr. Stephen Correa is a pulmonary physician, a long friend and colleague, and he is a fantastic clinician, consultant here at Suburban and other various hospitals in Montgomery County. And he is going to speak to the monoclonal antibody treatment options for a person who has falls into the category of mild to moderate disease with COVID. And the reason it's important that he speaks to this today, and I asked him, and he's so gracious with his busy schedule at work, so he's going to go first, is that I think we're focusing so much of our efforts on the vaccine only. And I think the vaccine is critical in our treatment regimen, I call it, for COVID, but we have to remember people still will get sick with COVID, and we want to prevent them from progressing any further and preventing hospitalizations. So I think the number one thing in prevention is wear your mask. Don't let your guard down. The second today is Dr. Correa will talk to you about a treatment option that's an outpatient. And then Dr. Andrea Lerner, who I've gotten to know very well over the pandemic. I've actually never met her in person, believe it or not, but she's a fantastic friend now and colleague and my partner in crime when it comes to giving fantastic talks to the community. Her knowledge is unbelievable. She is a infectious disease trained and board physician who actually works in Dr. Anthony Fauci's office at the NIH. She's also a clinician who consults on the infectious disease service at the NIH. So I want to thank you both for being here today and giving us your knowledge base that will be tremendous to the community and for your time, as I know both of you are extremely busy. So without further ado, Steve, I'll let you take the floor, and thank you both again.
So I hope that you can see my presentation. Let me just see if I can share my screen, and also, can you all see this? Yes, no? So I'm in pulmonary practice. I've been very, very busy throughout the pandemic, as you may have imagined. And I know that the big question on everyone's mind is, when can I get my vaccine? When can I get my vaccine? And what are the precautions about getting the vaccine? But as Sonia just eloquently pointed out, we still have patients who are going to get the coronavirus, and what therapies do we now have for patients? And my focus is really on outpatients, because the inpatient program has a fairly set schedule. So I wanted to make sure that I talked about the monoclonal antibody, which is a new and developing therapy for patients who have who have coronavirus infections, but are not sick enough to be hospitalized. And I'm using myself as an example. So here's my case report. I'm a 66-year-old, mostly healthy pulmonologist who developed fevers and malaise on 12/9. My past medical history is only notable for asthma, Onbrio 200, and Montelukast, being overweight, and having some sleep apnea. Now, I like to think that I'm pretty good about my coronavirus precautions and PPE. I wear my mask regularly. I've been wearing a face shield for the last month, and I'm very consistent with my hand washing, augmented by the purchase of a new Apple Watch 6, which now has a little gizmo on it that will listen for my hand washing and tell me when I get to a count of 20. So on 12/9, I developed some malaise and fevers. The week beforehand, I had been asked to see consult on 4 patients who were on the coronavirus ward. On 12/10, I developed 101 fever. I had a nasal swab that was positive for the mRNA for the SARS-CoV-2 virus using the highly sensitive Hopkins lab. The results were back in 1 hour. I canceled my office visits, I arranged for hospital coverage, and I started on-home quarantine. I also tried to arrange for the monoclonal antibody, and the next day I received the infusion of bamlanivimab at the Tacoma Park Infusion Center, the only one that is available in Montgomery County. I did not have any fevers that day. I did have some aches and pains and some low-grade fever. I had dizziness, malaise, and a dry cough. I added some promethazine with codeine cough syrup. I had my pulse oximetry and heart rate checked, and I self-isolated myself at home with a resumption of a shortened work schedule, seeing patients virtually. On day 6, the nasal swab for my wife was negative. I was celebrating that because I was terrified that I was going to give it to her. She's another physician in Northern Virginia. My office staff was also negative, but I had a low-grade temperature. The next day, I was able to, I had plans to stop the self-isolation. I had to delay that for a couple more days because I had the low-grade temperature. Since that time, I had 2 negative swabs for the coronavirus, and I'm fully back to work without any discernible sequelae. So my pitch is, yes, we want you all to get the vaccine, but please remember the monoclonal antibody. So what's the evidence that it works? Well, there were 465 patients in a randomized, double-blind, placebo-controlled clinical trial with mild to moderate symptoms. They all received within 3 days, they were all seen within 3 days of obtaining a positive coronavirus test. There were predetermined secondary endpoints of coronavirus-related hospitalizations within 28 days of treatment, and as you can see, I hope you can see, the placebo arm had about 150 patients. Each of the 3 dosing schedules, 2,800 milligrams and 7 grams of monoclonal antibody, each had 100 patients in them. And in the placebo-related patients, hospitalizations or ED visits within that 28-day period occurred with 10% of the patients. And in those who received any dose of the monoclonal antibody, hospitalizations reduced to only 3%. And as I may have mentioned, in Montgomery County, the only authorized infusion center is the one at the Tacoma Park. It's the old Washington Adventist Hospital campus, if you're familiar with that. So who is a candidate for getting the monoclonal antibody? It's, as in my case, everyone or anyone over the age of 65, and those under the age of 65 with qualifying conditions, diabetes, renal disease, cardiac disease, asthma, or pulmonary diseases. I think those are the major categories who are at risk for doing poorly when they get COVID-19. There are certain exclusions with this monoclonal antibody. The monoclonal antibody is probably associated with worse outcomes when administered to hospitalized patients, especially those requiring high-flow oxygen. It is a monoclonal antibody specifically directed against the, if you will, old spike protein of the coronavirus virus. Theoretically, it could reduce the recipient's abilities to generate antibodies against this disease, and it must be administered very early in the disease. The trials were done with patients within the first 3 days of receiving the diagnosis. The infusion has been extended to the first 10 days but day one is when you start having symptoms. So it's a fairly urgent matter to consider patients for this and to get the infusion form filled out, which is readily available through a variety of websites. Now, this is a monoclonal antibody that is specific for the spike protein, and we really don't know how effective this monoclonal antibody is going to be against the new United Kingdom variant of the coronavirus. So that's something to consider, but we really don't have any data, I think, on this. So what are my take-home points? Wear the damn masks. When it's your turn, try and get the vaccine, but when you have a patient who has coronavirus or COVID-19, consider whether they are a candidate for this monoclonal antibody. And number 4, to encourage everyone to get the vaccine, everyone who is eligible and available to get the vaccine when their term comes up. So I think that's it. I hope you were able to see some of the slides, and I'd be happy to take any questions that people might have at this point. One of the concerns that I have, and many people have, is that we're not giving as much of the infusions as we had predicted. And I think there's a variety of different reasons for that. Number one, a lot of people don't know about it, including some of the practicing physicians. I think another one is that there are some people who are afraid to get either the vaccine or the monoclonal antibody. They're afraid of potential side effects. It's a 4-hour procedure, but the infusion itself only takes 1 hour. It's rarely associated with any side effects or any other issues. And I think it can importantly reduce the likelihood that people will have serious disease. In my case, I don't know if it saved my life, but I'd like to think that it did. There is one other caveat that I should mention, and that is people who receive the monoclonal antibody cannot get the vaccine for 90 days after they get the monoclonal antibody. So that's a caveat. Andrea probably knows this better than I do, but the studies that I've seen suggest that when you have the coronavirus infection, you have protective antibodies for at least 8 months after the infection. So there are some experts who have suggested that people who have had the viral infection go to the back of the line as opposed to the front of the line, but the recipients of the monoclonal antibody do have to delay getting the vaccine for 90 days after the infusion is.
Dr. Correa, there are 2 questions from our audience. What is the cost of the monoclonal antibody treatment?
It's supposedly no cost, and it may be billed to the insurance companies, but that's an important point that I did not bring up. And that and many other costs associated with coronavirus vaccine and other things, it's not supposed to be out-of-pocket costs for the patients.
Yes, I'll just jump in, just a couple things. So right now, at the moment, the monoclonal antibody, so there's one by Lilly and one by Regeneron that are both offered at the alternative care site in Tacoma Park. So there are 5 alternative care sites in the state of Maryland. One is in Baltimore, and the closest to us in this area is Tacoma Park. There is no cost. This is all federally and state funded at the moment. And if people need transportation, they're willing to help with transportation to get you to the infusion, because that's how important they feel it is. And they do realize during this pandemic, it is difficult for some people who are older to get transportation set up. Not everyone's savvy with apps with Uber, et cetera, or getting friends or family or someone to transport them. So in this they are actually willing to help with transportation, and we can provide additional information to the community regarding what's the phone number to call, but really should be sort of conducted by your primary care doctor in terms of setting it up.
There's also one more question for this specifically. How do you go about recommending the infusion? Is it through your doctor? Does a hospital play a role in this?
So it is really not, although it is a program that's being promoted by the hospital, because obviously hospitals have in this day and age an incentive to avoid people getting sick enough to be in the hospital. It is really for the community-based physicians. It's for private practitioners such as myself. So it is important for doctors to know about it. I think in this day and age it's also important for patients to know about it so that they can ask their doctor whether or not they are an appropriate candidate for this.
Thank you.
Thank you so much, Steve. Any other questions for Dr. Priya?
I apologize for this, but I told Sonia that I'm scheduled to start seeing patients at 1:30, so I will be leaving, I think, Andrea, partway through your presentation, and I apologize about that.
Yeah, we totally understand, Steve. We can't thank you enough. I know how busy you are, and I'm so glad to see you again. You look great, and if there are no further questions, we'll move on to Dr. Lerner's presentation.
All right. Eleni, are you going to be sharing my slides, or I can also give it a go? Maybe I'll try, and we've got you the backup.
And if not, I'll be your backup. Yeah.
Perfect. Okay. Well, I want to thank the team from Suburban for inviting me today and to talk to you all in this webinar. All right. Let's see. Are we able to see?
Yep.
Okay,
I
great.
can see it. Great.
Great. So as Dr. Qasba mentions, my name is Andrea Lerner. I'm an infectious disease doctor and a medical officer at NIAID, National Institute of Allergy and Infectious Diseases, right across the street from Suburban at National Institutes of Health. So, all right. Did you see my slide advance? That's my next question. Okay, good. So then I should be good. All right, so I'm going to talk with you guys today about the COVID-19 vaccines and cover just a few broad points here. You know, this first slide, which I'll get into, but talk about kind of what vaccines are available and out there, because I know it's been a whirlwind with all the clinical trials and different things in development. Talk a little bit about how these particular vaccines work, because this is a new type of vaccine on the scene here, and a lot of there are a lot of misconceptions, and hopefully clear some of those up. I'll talk about some of the clinical trials that have shown us the safety and efficacy of these vaccines, and then we'll have some discussion. So first of all, I guess, which vaccines are available? Just to clarify things, there are two vaccines that are under emergency use authorization, so authorized by the FDA and recommended by the CDC to prevent COVID-19. And you probably have heard, this is the Pfizer BioNTech COVID vaccine and the Moderna COVID vaccine. These both are 2-dose vaccines, and the Pfizer flavor is 21 days apart, and the Moderna is 28 days apart. So 2 doses are needed to get the full protection for both of these vaccines. In terms of how do these vaccines work? So first, just to take a step back, vaccines overall work by essentially showing your immune system a little piece of a pathogen so that you can recognize it when you encounter it and have an immune response against it and be protected. So in terms of these vaccines, the thing that they're training your immune system to recognize is the spike protein, which is a protein that helps the virus that causes COVID-19, SARS-CoV-2. It is actually how it attaches to the cells and infects the cells. So these vaccines, the way to think of them is they train your body to recognize this piece of, the virus that causes COVID, so that if you are to encounter it, you'll be able to, have an immune response against it and be protected. So this protein is called the spike protein. So these vaccines work using mRNA, and that's, a lot of letters there, but really what mRNA is, it's in our bodies all the time. And basically it's an instruction template for our cells to make protein. So our cells all the time, every cell in the body, is, or pretty much every cell in the body is using mRNA as kind of a template to direct what proteins we make. So what these vaccines are the mRNA in the vaccines instructs our cells to make to make this spike protein so that our immune system can see it and learn how to fight against it. So that's broadly how these vaccines work. So considering, that this is a new concept for a lot of people, and although people have been working on researching the mRNA vaccines for a long time, these are the first that are out there in the general population. There are a lot of misconceptions about them, and just wanted to clear up just some of them. I just want to put out a plug. The CDC has a lot of great information on their website as well. So I would encourage anyone watching this webinar to peruse the CDC website if you're interested in kind of learning more and digging a little deeper. But just up front, these vaccines, it's impossible for them to give you COVID-19. That's biologically impossible. So they can't give you COVID. The vaccines, another thing you might be hearing, they don't affect or interact with our DNA in any way. So that you can take that off the table. And the vaccines have been evaluated, their safety and effectiveness has been evaluated in big clinical trials, which I'll get into. So both of these trials have been published in the New England Journal of Medicine. And, I know with COVID, a lot of information comes out first with press release, and then things are later published. So it's kind of a new way that we're hearing about a lot of scientific results, but the results of both of these trials are published. So, freely available for everyone to look at. And the first one I'm going to walk through, and they're pretty similar. The Pfizer vaccine, this was published in the New England Journal on December 10th. And basically, the high points here, a 2-dose regimen of this vaccine was 95% protective against COVID-19 in people 16 or older. This vaccine included 40,000, over 40,000 people, as you can see here. And the safety profile was very good. The incidence of serious adverse events was low, and it was similar between the vaccine and the placebo groups. So the Moderna vaccine also, results of the trial published in the New England Journal on December 30th. You can see sounds pretty similar to the previous slide. A 2-dose regimen of this vaccine was 94.1% protective against COVID-19 in people who are 18 or older. This trial was over 30,000 people. And again, the incidence of serious adverse effects low and similar between the two groups. One thing to be aware of, people are commonly, like many vaccines, experiencing local reactions, and it's not uncommon to the day after, or as your immune system is learning how to fight the coronavirus, have things like fatigue, muscle aches, or symptoms that show that your immune system is in full drive, learning how to fight the coronavirus after these vaccines. So the way that this has worked, and the way that things work with the process. So You know, the FDA has reviewed all of this data and granted both of these vaccines an emergency use authorization. And then the CDC provides recommendations about who should be, you know, who should get the vaccine. And, you know, they have published on their, you know, website and out there some recommendations for vaccine prioritization. And, you know, to both to protect themselves and also demonstrate, you know, confidence in the process and kind of demonstrate that to the public. You know, it's, you know, Joe Biden and Kamala Harris have both publicly received the coronavirus vaccine, and some of our NIH leadership here, as you can see, Dr. Collins, Dr. Fauci, and Alex Azar also received the vaccine at the end of December. So something that is very important to recognize with the vaccine, and Dr. Qasba has touched on this, you know, we know that the vaccine is you know, very good at protecting people against getting sick with COVID. What we're still learning, and what I, you know, think will come out as more studies are done, you know, the effectiveness of the vaccine to prevent transmission. So meaning that somebody could carry the virus, maybe not get very sick themselves, but actually be able to give it to other people. That is still not clearly, that's still being figured out, and that's not yet known. So with this vaccine rollout, it's really important that we still actually do the things that we've been doing to prevent transmission of coronavirus all along. So that includes masks, distancing, avoiding crowds. I'll get into that in the next slide, but you know, even if the vaccine is protecting someone against getting sick, we have to still at this point say we don't know how well it's going to protect against people being able to carry the virus and pass it to others. So that's an important consideration. Also, as we know, it's going to take time for the population to be vaccinated, obviously. So it's not like an off-on switch. And also, you know, these vaccines are very effective, but we don't yet know, you know, they're not 100% effective. And, you know, everyone is an individual, and we can't assume that it's going to be 100% protective for every individual, because that's not the case. So these things are still going to be very important until things are, you know, the community transmission goes down basically and is more under control. So what are some things that are important to do to prevent getting and transmitting SARS-CoV-2, the virus that causes COVID? Because this really can't be said enough. So wearing masks and face coverings. If you have the virus, keeping it in, preventing it from, you know, you're spreading it to others. Maintaining physical distance from people, avoiding crowds and being in congregate settings. Outdoors, because the air is moving and dispersing things, outdoors is going to be safer than indoors. And frequent washing of hands. So that can't be said enough. And another, you know, just in stat that is on the CDC's website that I thought I would share, there's a tracker of how many vaccines have been distributed. So about, this is as of earlier today, over 9 million people in the US have received the first dose of the vaccine. So, or either vaccine. And I think that's my last slide. So I will stop there and stop sharing my screen.
Thank you, Dr. Lerner. We have a lot of questions for you and Dr. Qasba. The first one of them being that we received, basically, and I understand this too, grandparents, they want to know if they received the vaccine, both shots, when they can spend time with their grandchildren again.
Well, I'm not sure. I think this is so I think this is a hard question to answer. And I think my philosophy is this, that we have to learn to live in the times of COVID, right? So as an example, I have parents who are older, who live in the community as an example, and I see them, but I always wear a mask. And my dad will be he's actually on, he's the first person to run to get his mask when I come over to visit. So I do visit, but I wear a mask. If I'm sick, obviously I'm not going to go visit anybody. So I think you can, I guess my point is we shouldn't rely on the vaccine as a way for us to be able to be very free and drop our masks and be around our loved ones as if COVID doesn't exist. So that's my, from a practical perspective, but I'll let Dr. Lerner, go ahead and comment on that. And I think this is generally because all of us want to be around our loved ones and family, every single one of us. It's been very difficult for all of us, but I think we have to learn to continue to be safe, even though we have a vaccine that is going to be soon, an opportunity for everyone, regardless of age. At least over 18, to be able to offer the vaccine.
Yeah, Dr. Qasba, I'd agree. I think that thinking of the vaccine as an off-on switch is the wrong way to think of it. Kind of important points. Although, the clinical trials have shown that, that the data that we have so far, it's very protective, not 100%. So there is still some element of risk to yourself. And also we don't know, we're still learning about the ability of the vaccine to block transmission. So you would have to consider who you're going to be coming into contact with. So I think until we know more information, taking precautions like masks and distancing to prevent, spread of COVID is the wise thing to do. But of course, some degree of, personal judgment and kind of risk-benefit balance comes into play. And just like Dr. Qasba is saying, COVID has been a part of our lives for the past year, and many things are complex, to say the least. So that would be my 2 cents on that one.
Great, thank you both. Another question is, they write, I'm not concerned about the short-term issues with the vaccine. What problems might occur 4 to 6 months in the future? How long have people been followed, I suppose, in the clinical trials for the vaccine?
Mm-hmm. So in the clinical trials, they were followed for at least 2 months in both of those clinical trials. And as people continue to get the vaccine under the emergency use authorization, I should say the people in the clinical trials are still being followed. And as people who are not in the clinical trials are getting the vaccine under the emergency use authorization, the CDC and FDA are tracking, safety as well. So, yeah.
Great. One question is, if we had mild COVID in March and we received the vaccine, if we had mild COVID in March, will the vaccine have the same effect in the body as it did if people who've never had COVID? So will the body react the same if people have antibodies for COVID to those who have never had COVID before?
Yeah, I would expect it to. We know that after you have COVID, you're probably protected, or immune for some period of time, but we don't know exactly how long that is. So the answer would be yes. I would expect it to be similar. And having had COVID is not a reason to not get the vaccine. To be clear, so. You may want to talk about the timing with your doctor, but having a history of COVID is not a reason to not be vaccinated.
Okay. Dr. Qasba, do you want to also chime in as well?
Yeah, no, so the only thing I was going to add is I know there's data to show that those who get the monoclonal antibody should wait 90 days before getting the vaccine. So that's the only caveat if you actually have COVID and receive the monoclonal antibody.
That's a good point. Yeah.
Dr. Qasba, do you know if children aren't vaccinated, how will affect overall herd immunity?
So I'm not sure we know that yet. We do know that the reason a child, as an example, is positive, is because they live in a home where family are positive. So they have to have pretty significant exposure. And that's generally what we're seeing, even in our ER here. We're not really sure why kids are not getting it. It's, like adults are. We do know that there's been data to show that there's a pretty significant inflammatory response similar to Kawasaki syndrome that we're seeing in kids called MIS. And so, I don't think we know a lot yet, but I guess the hopes is that if we can, prevent the transmission in adults, that will sort of spill over to protecting kids. But the studies themselves, and Andrea can correct me if I'm incorrect, is two populations, and I think children, and I'm not sure which vaccine is it, Pfizer or Moderna. One is you can use 16 and over, and the other is 18 and over. And then pregnant patients have been excluded from these studies as well. So if you're pregnant and are considering the vaccine, you should speak with your OBGYN directly about sort of the risk benefit of receiving the vaccine while you're pregnant.
Thank you. Someone had a question about how long the vaccination will be effective. Is it like an annual flu shot at this point, or is that, or do we not know the answer to that yet?
Yeah, that's the case. The short answer, we don't know. So as people are still being followed, the clinical trial, people are still being followed, it will take time to know that.
Okay. So the vaccine was first given out to healthcare professionals. Is there a time when it's going to move forward to the over 75 population? And do you know if there's been any discussion on how it's going to be given out in Maryland, in Montgomery County?
So I can maybe speak to that a little bit, and Andrea, please, if there's anything additional, but I know there's been a lot of discussions internally here at Suburban, in the Hopkins system, at the state level. I think, we're going to start in the state of Maryland at 75 and over will be the next sort of population. We're trying to figure out what will be the most practical way of immunizing people, and I don't think we have quite that plan in place. I mean, it could be hospitals, pharmacies, schools, where you kind of get get in line. I don't think they have a plan yet, but definitely there are people obviously working on it, because I can tell I get a text just about every day from people, when can I get vaccinated? And unfortunately I don't have any answers yet, but there are several meetings and discussions at different various levels to figure out how best to disperse this in a very, not in a non-chaotic way.
Right. Yeah, there was also another question. Maryland seems to have been slower in neighborhooding states. Why is this? Does Montgomery County have an especially slow rollout? So
I think it's very like state to state variation. I wouldn't say that, I kind of look at it that Maryland's probably trying to be very cautious about how they roll it out, so it's rolled out smoothly, which I think is good, as opposed to just mass vaccination in great chaos can probably run into a lot of problems. I do have to say also the alternative care sites, one of which we mentioned earlier in Tacoma Park and one is in Baltimore, may be involved in this because they're already administering the monoclonal antibody. These are like COVID Center of Excellences, we call them in the state of Maryland. There are 5 of them, and there are various ones throughout the country. But that's sort of, they may play a role too. That we're not sure yet how this is going to all roll out.
A lot of unknown questions. Should someone who's had a severe allergic reaction to antibiotics be concerned about getting the vaccine?
So I'd say anyone who's concerned about getting the vaccine, the first thing I would say would be talk to your personal doctor who knows you, because you know, they know they know your personal history and can give advice. You know, in general, the CDC's contraindications, you know, to getting the vaccine is if somebody's had an allergic reaction to the vaccine, the first dose, you know, a severe allergic reaction to the first dose or any of the ingredients that are in the vaccine, or an allergic reaction just to an ingredient that's related to one of the ingredients in the vaccine. But you know, antibiotic allergies, I would not, you know, consider a reason not to get the vaccine at all. But for, you know, your personal situation, run it by your doctor.
Good advice for anything. What if you get the vaccine without knowing that you're infected with COVID-19? Can you get the monoclonal antibody without waiting for 90 days after the vaccine?
Yeah, so the monoclonal antibody can be administered after vaccine. It's just the other way around, where if you receive the monoclonal, there's going to be a delay in getting the vaccine.
Mm-hmm.
Someone had a question about, could you provide clarification on what the effectiveness percentage means? If the vaccine is 95% effective, does that mean that the vaccinated person only has a 5% chance of getting infected, or only a 5% chance of not getting seriously ill from COVID?
Yeah, so what that means is that, you know, the trials were designed to look at people who got sick from COVID. So when they had the trial, you know, half of the people got the vaccination regimen, half of the people got placebo, and you know, there were X number of cases of people who got sick from COVID in the vaccine group, and X number of cases of people who got sick from COVID in the placebo group. And that 95% number comes from calculations involving those numbers. So yeah, so what we know is that 95% is related to the whole population of the trial. It's not necessarily for one individual. But yeah, we're talking about risk, you know, how effective it was in preventing the group of people from getting sick from COVID. So not getting we don't know about, you know, yet about asymptomatic infection or anything like that.
Okay. We also have some questions about people wanting to know if you received the Pfizer vaccine for the first dose, how important is it to get the same dose with Pfizer? I would say yes, but I would know.
Yeah, you definitely, you know, the way that this was studied and the strong recommendations are you get the same first dose. You get Pfizer, you get it for both doses. If you get Moderna, you get it for both doses. So they're not mix and match.
Okay.
Eleni, I wanted to just make a couple comments, I think, because I see some of the questions. So one, and this is sort of off the vaccine track, but just so that I don't forget about them. So one is talking about testing in terms of COVID testing here at Suburban. So we do have a drive-through in which you need a prescription from your primary care physician. And we're sharing with Sibley where we're alternating Saturdays. But to make an appointment, you can get a swab done. The test result is usually resulted the next day. We do not have 1 hour test turnaround. Generally speaking, that's not the case because that's not how we can build it into our system here. So generally speaking, you should get the result the next day. You know, it shouldn't be 2, 3, or 4 days at all. And they are PCR based, they're not antigen based, just so that everybody is aware of that. PCR is very sensitive and specific. Antigen we know is not as sensitive. That's why if you get an antigen test and you feel like you're still having symptoms, the recommendation is to go ahead and get a PCR test to make, you know, to basically make sure that you don't have COVID-19. The second, I see a lot of questions about the monoclonal antibody. So we're going to be doing a similar Zoom session like this for the community physicians and the directors of some of the SNFs in the area. We've actually done one already just to bring awareness. One of the reasons we're doing this in the community, and as I think is as a community member, it should empower you to ask the question to your primary care doctor, so that you can say, hey, in case your primary care doctor doesn't know about it, there's a monoclonal antibody offered at the alternative care site. But there's a form, a referral form that has to be filled out by your physician. Physicians are becoming aware of it, so that they can go ahead and make sure that they can offer this to you as a patient. So we're trying from different angles to educate the community about the monoclonal antibody and the opportunity at the alternative care center for mild to moderate disease. And you have to qualify for that. So just remember that. That's just an important piece as well. But I didn't mean to get off the vaccine track. Sorry about that.
It's okay. While you're on the COVID testing track for just a minute, I feel like there's some misinterpretation. If you get if you get tested for COVID-19, that doesn't necessarily mean that the moment you get your result, that's not vaccine, I'm sorry, the moment you get your COVID test and it says you're negative, that isn't the moment that you go and hang out with your 88-year-old grandmother, correct? Because I think there's this misconception, oh, I'm negative, or I don't go anywhere, or I got tested and I don't have the virus, so I can go hang out with grandma. So I wanted the experts to also kind of just answer to that, because I think there's definitely, since the holidays, there's definitely this kind of misinterpretation of what a negative result really means.
Yeah, I'll just make a couple comments, and Andrea, please chime in. But basically, the way I look at this, and I think most of, and I think Andrea might agree, it's the test that you get at the time of point that you get it is the test for that moment. And why I say that is because if you have been around someone who has COVID-19, because remember, a good percentage of people are walking around who are asymptomatic and don't realize they actually have coronavirus, are able to spread it very easily, hence the importance of wearing a mask. Now, if you've been exposed to someone, there's an incubation period of 10 to 14 days. And so if you've cleared that 14-day period and you haven't developed any symptoms, then, and you haven't gotten tested, that just means you have not developed symptoms of COVID-19. Now, if you test positive during that time period, and people are like, oh, should I test myself every day? And I'm like, no, you test if you're symptomatic, wear your mask to prevent asymptomatic or any type of transmission to occur. So I think people rely so much on testing that, oh, I'm negative, so I can go ahead now and be around whoever I want and not wear a mask. No, it's that you're negative, period, at that moment. Still important to wear your mask. But Andrea, I'd like to hear from your perspective what your thoughts are.
Yeah, no, I completely agree. I think it's, they're using testing as a standalone strategy to prevent transmission. There are many, many real world examples where that did not work. And the reason is because exactly what Dr. Qasba is saying. When you get a test, it means that your test result was negative at that exact moment. So it could be negative because you don't have COVID, you're really negative. It could be negative because it's a false negative of the test. It could also be negative because you have the virus and it just hasn't replicated up enough to be picked up by the test. So I find that a positive test is very helpful information in that, in the right setting, or most settings, it's going to mean, that you have COVID. But a negative test is one piece of information, but it's not, it is not a, get out of jail free card. And people can also be, it takes time for the test to come back. People can have an exposure after the test comes back. And I would just point to, the many examples out there where, testing without anything else in place led to outbreaks. So.
Thanks. I keep saying Andrea, I should say Dr. Lerner. So
Oh, no.
thank you for that. But I actually wanted to make one other comment. And I think people get confused on two terms. One is the word isolation and the other is quarantine. And I think isolation is if you, like if I was positive and I live with people at home, I need to isolate myself from them. Someone who needs to quarantine is now my family who's been exposed to me need to quarantine themselves to now not be around somebody else just in case they turn positive or become symptomatic. So the quarantining is that 10 to 14 days, and the isolation is, and then there's scenarios in when you should come out of isolation based on significance of illness, whether you were hospitalized, et cetera, or you were just at home. But generally speaking, it's 10 days. You can come out of isolation from your positive test as long as your symptoms have close to resolution and you've been afebrile for 24 hours with no antipyretics. So, but please talk to your doctors about these details, but I just want to make sure that terminology, I think people get really confused and kind of use it very interchangeably. But Dr. Lerner, if you have anything else to add, I think, you know, to that.
No, I agree. Yeah, they're like in the media and just, you hear people using them like they're the same thing, but I always will remember you isolate if you're ill or if you have a positive test and you're not ill, but,
That's good.
but yeah, it helps to remember.
Yeah.
Thank you. Thank you for clarifying that. There is confusion. So let's just go back to vaccination. So people with an autoimmune disease, can they be vaccinated?
Sorry, can you broke up there for a minute.
I'm sorry. People with an autoimmune disease, can they also be vaccinated?
Yeah, so we don't really have data in that population. So if, you know, I would encourage people to talk to their individual doctor about, you know, their recommendations.
Okay, so we have 3 more minutes left, and I wanted to give you both the final thoughts of the day. Dr. Qasba?
Yeah, I mean, I think I see a lot of other questions about home test kits and stuff like that. So, you know, it's all about the sensitivity and specificity and the way the testing is performed that you have to remember. So, you know, we know, and I'll let Dr. Lerner speak to this, we know the PCR testing, which is a deep, you know, and a deep nasal swab is going to be your most sensitive and specific in terms of results. You know, there are all these oral swabs that you can do, you know, but I personally, from the data that I know, that does not always result as a very sensitive and specific test. It's also about the method that the test, is it a PCR or an antigen, which really makes the difference in terms of the reliability of the result at that time point that you're tested.
Yeah. No, I would agree. I think testing, I don't mean to downplay its importance at all, because it's an important piece of the, you know, prevention and kind of control of transmission strategy. But yeah, since it, you know, the performance and predictive values of different tests really vary by which one you're talking about. So yeah, I guess my closing words would be, you know, I think it's an incredible feat of science that we have a vaccine for a new virus, you know, out there within a year. It's really amazing. But, you know, it's, as we can see, it's not an on-off switch, you know, it's taking time to roll out. There are still things that we don't know about it in terms of, you know, how effective it's going to be to control passing on the virus. So keep up with the known, you know, public health prevention measures while, you know, the vaccine rollout is ongoing. So, you know, things that we know are going to be effective to control transmission of COVID.
Yeah, and I just like to add to that, don't drop your guard, and that means don't drop your mask. So keep your mask on. You know, we have months still to go through. I know everyone's very fatigued doing this. You know, it's been really hard mentally on people, young and old, and the whole spectrum. But, you know, we're in this together. You know, we'll get through this. But just be safe, wear your masks, look out for each other, because I think this is not a a disease of yourself. It's really a disease of the public and the health. So what you do impacts people around you. And I think that's really critical to remember, because, being selfless during this time is probably going to be more important than you can imagine. So, but I want to thank all of you for coming on. Dr. Lerner, you're awesome as usual. Partnering up with you is amazing. I always learn so much. So thank you for your time, your knowledge, and all the work you do at the NIH and Dr. Fauci's office. Very well respected group of individuals. Eleni, thanks for sponsoring this and getting this out and rolling it out. And thank you, everybody. And I'll let you go ahead and give closing remarks. Thank you.
Thank you, Dr. Qasba. I feel like the same. Your leadership through this difficult time has been inspirational for all of us. So thank you, those that work with you. Thank you very much. And Dr. Lerner, such a pleasure to virtually meet you today. I thank you both, and I thank Dr. Correa as well for taking the time out of his busy schedule. Perhaps he can come back and do a presentation on just monoclonal antibody treatment as well. But thank you again. Thank you everyone for participating today. And again, thank you. Wear your mask when you're able to get vaccinated, and just please stay healthy. Thank you.
Thank you, everyone.